Ani Bojo, welcome everyone who's just hopping into the room now. Um, my name is Shanti Aguilar Cardenas, and I am the Ontario NEIHR Coordinator. Welcome to this month's installment of the Ontario NEIHR monthly webinar series with our guest speaker, Dr. Mikaela Gabriel. So before I pass it over to you, Mikaela, I will just remind folks of a few housekeeping items. So this webinar is being recorded and will be uploaded to our YouTube channel. So folks will be sent the link to the YouTube recording, and you can share this with your network or refer back to it if you need to come back to the presentation. We will also be sharing a short survey that I'll pop into the chat at the end of the presentation, and we appreciate your feedback. And lastly, please, we encourage folks to use our Q&A feature to ask any questions throughout the presentation. Unfortunately, for security purposes, we aren't able to allow folks to speak, but you can type in your questions in the Q&A and I'll be monitoring that. So that's it from me for now. So I'll pass it over to you, Mikaela.
Okay, thank you,
Great.
Shanti. Thank you, Miigwech. Thank you, Clay, for that beautiful opening. Thank you for those of us joining us online, or if you're watching the YouTube recording, thank you for joining us whenever you may be here. I'm gonna share my screen and get us rolling. And screen sharing, making sure everything's okay. Okay, slideshow from beginning. All right, it looks like we are in business. So I'm just going to float us up here. Hopefully that's okay. I won't be able to see any of your kind questions, so I apologize for that. Let's move this bar somewhere it needs to be. Okay. Hello. Hi, everybody. My name is Dr. Mikaela Gabriel. You may remember me from such short films as previous webinars, one in which I was speaking on Indigenous education and my own education journey in Western systems, called Gina Masuti, as well as the Kugagi Piramatsuwin study, where we looked at exploring vaccine hesitancy during COVID-19. So today I'm going to be talking a little bit more about a project that actually was just launched. The project report, that is, the completed report was just launched. And I'll be telling a little bit about the results of that experience, the procedures of that experience, as well as some of my own reflections and actually a little bit of my history. So today's presentation is called Policy and Practice Prescriptions from the People. I love a lot of alliterations and I like to have a lot of fun with sharing knowledge. So this will look at healing and health for Indigenous peoples accessing primary care settings. A little bit too about me as I advance my slide is I did introduce myself as a doctor, but Kwe Teluisi Wetwelamit Wapewa. The first spirit name I was given is Wetwelamit Wapewa in Mi'kmaq, which means laughing swan. I am Italian in Mi'kmaq Vukdaanguk, which is now known as Newfoundland. And I'm actually not that kind of doctor. We're talking about primary care settings, but I'm actually a clinical and counseling psychologist. I have worked in hospital settings, a variety of different hospitals. And I have, as you'll see, I have strong connections to hospital settings. That being said, I am a psychologist. So you might be wondering, not that kind of doctor. I'm a different kind of doctor. But you might be wondering why I'm kind of exploring and talking about, different aspects of care. But as we find out, they're all technically related to care in different ways. And I'll share the story of how this project came to be in a couple slides. But I think it's also important to reflect on also, and something I'll be sharing throughout is how so much of how this project came to be and the results of it actually started much, much earlier than when the contract really began. So we'll see how that unfolds. And now I mentioned I'm not that kind of doctor. I'm also Dr. Gabriel, but I'm not that kind of angel either. The name Gabriel, the surname Gabriel, is a recognized Mi'kmaq name from Ukdamguk, from especially the western side of Newfoundland. This is an excerpt from a dictionary of surnames, I believe specifically in Newfoundland. And you can see here it recognizes us as the Micmacs of Newfoundland. And carrying this weight, this name, this beauty of this name, this angelic name has not always been something of positive recognition. I'm able to bring it with the term doctor, but for a long time, it actually meant being recognized and labeled as a savage on our baptismal records. It meant the endurance of racism, poverty, steep, profound in poverty, job insecurity, and exclusion that haunted and unfortunately challenged generations of my family. Here's my grandpa, Norman. This was a recognition in a published article in the newspaper just closer towards the end of his life. When he was about 88 years old, he was recognized for being the oldest Indigenous person on the west side of the island. And while it described him as a living legend, these types of accolades and respects was only offered truly towards the end of his life. He describes in this article, as well as in other family stories, not even being allowed on buses because he was Mi'kmaq, because he was known to be a quote unquote Indian. Later, throughout his persistence, his hard work, his efforts, he was recognized and had that name given to a stream in, I believe it was Labrador, as well as a road that was named after him. But for unfortunately many of our people, these signages, these aspects of respect come after decades and decades of distrust, of racism, of enduring tremendous challenges. Now, again, the name Gabriel, my family have worked very hard to try and protect our peoples, to protect our lands. That right there, you can see my mouse move around, the guy with the afro, that's my dad trying to, in 1979, actually trying to establish an Indigenous park specifically for Indigenous people that would be both a land preserve as well as a place for us to go and practice our medicines. But unfortunately, because of many things that we've covered in a lot of the literature, but also from our lived experience, we understand that employment insecurity, frequent high turnover rates, as well as geographic structures for employment on the island of Newfoundland itself, impacted many people, including my dad, to take them away from our traditional territory and instead going closer and closer to urban centers, closer and closer to different places for different aspects for opportunity. And that led him not only to the mainland, but even further west to Toronto, where he met my mom. I told you. So my story actually starts in a hospital because my dad ended up working across a variety of different aspects, but he really loved taking care of people. He worked in a variety of different counseling roles and it eventually found his way into healthcare. And he was working as an orderly when he saw this lady here and he said, "That's the one for me. That lady looks so cute." And she was working as an intern at the time. And the hierarchy, the hospital hierarchies between orderlies and interns is something that Grey's Anatomy wouldn't even touch. It is a very steep divide. But I asked him once, I was like, "What was it that really like attracted you to mom?" And he was like, "Oh, well, that's easy. Like, obviously she was a cutie, but and she was this beautiful doctor. But for he's like, I noticed that when she was in emergency settings, when she was, putting together patient care, she always protected the patient's dignity. So when someone was coming in for a medical emergency, if they were uncovered more than they needed to be for the procedure, she made sure to cover the patient. She made sure that their respect and their autonomy and their dignity as a human being was covered to make sure they weren't unnecessarily exposed. And I think that's such a beautiful story, not only to highlight my sweet mom and her integrity, but when we think about going into these hospital systems, when we're at our most vulnerable, when we're not even conscious, our highest hope is that someone will care for our integrity and our dignity to that same extent. And we appreciate that as an admirable and appreciable thing, but we don't know if it's standard. And that's the concern, is anytime we enter into hospital systems, we have to take a risk and we don't know if someone is protecting us when we need them the most. Now, my mom is retired, so she's not there, but hopefully many people are still taking up this mantle. So my story begins because they met in a hospital setting. I was also born in a hospital. My dad actually became a paramedic later and retired to take care of me. And later over time, I would actually go on, like I mentioned, to work in hospitals. A lot of my internship and clinical training has continued in hospitals, and I feel quite comfortable there for different reasons. But again, that's not always the case. That being said, as much as my story starts in a hospital, we would still return to the land. So that's me with my grandfather. We were picking blueberries. I think I look about 6. I'm that little one that's curled up with him there. And we were gathering blueberries that particular day. And we would go and visit him in the summers. A large chunk of my time was spent there with him in just spending time together, getting to know each other. Those sweet memories that take care of us when the dark times come. But unfortunately, a large part of that time also was actually spent in hospitals as his health continued to decline. And towards the last weeks of his life, we were there at his bedside taking care of him as best we could, both with my parents' medical training as well as with the care and love that comes with sitting with someone through the hardships when they're floating, whether in and out of consciousness, when they're teetering towards that good night. We were there to support him and try and care for him as best that we could. And I think that was an important aspect to what I think about when it comes to providing different levels of care, is that effort of not only showing up, but trying to provide love, maybe gentle humor and medicine as best we can. But as my own clinical training has grown and as I've worked across different hospital settings, I've often kind of joked with my parents and my dad, and I was like, it's hard enough finding yourself in hospital, especially in psychiatric settings where I work. You have to unfortunately look at some of the hardest aspects that's bringing you into hospital. And then you find me, someone who's like trying to sit with that pain and sit with that challenge and understand it with tools and coping skills, but someone who's also going to provide some fun facts and try and get you to laugh in a good way, not at yourself, but in just to find humor and to restore some humor to your heart. And I was like, man, as if like life isn't tough enough. And my dad turns to me and he's like, he calls me Mouse. He goes, Mouse, I think you are the best thing for someone lost in the dark to find, you and your kind light. And that's a very beautiful thing to be told. And it was a very sweet honor to be shown that. But more and more, we also recognize that these aspects are rare, more and more in our realities and our histories for our peoples, especially across healthcare settings. There isn't a lot of kind lights. And actually, unfortunately, a lot of these systems don't take care of kind lights in different ways. Unfortunately, we see more and more ongoing darkness, ongoing challenges, different aspects through inquest, through inadequate care, through the recognition of anti-Indigenous racism, specifically in healthcare services, different levels of treatment being failed for patients, even after these news make headlines. Continued persistent aspects, not only in one hospital setting, but across different nations. And despite medical system apologies, we still recognize that and this was just published in 2024, these are very recent articles, these aspects are still tremendously present. Unfortunately, these concerns that we haven't changed because we haven't seen systemic changes. So that brings us a bit to this project. So I'd like to share a couple different aspects of the background. So I was contacted by Dr. Etsy Stewart, my mentor and previous advisor, and she had referred me to the Wellesley Institute, which is a nonprofit research organization located here in Toronto. And she connected me with them and said, "I think you can do a good handling of this project and make good work from it." So she connected me with them, and we talked about the option. And the purpose of this study was to explore primary care access for what we call equity deserving groups with a subpopulation for Indigenous people. So pretty much they wanted me to explore through qualitative data, through the voices and experiences of our people, what their realities and experiences were like in accessing primary care. What are the gaps? What things help them access primary care? As well as a second environmental scan to explore what cultural safety is like for healthcare providers and what we can, how I don't, and a little bit about efficacy. So how effective they really are. So I said, okay, should I do this work? And I said, okay, you know what? Again, I did that whole prelude about how, there's so much going on in hospitals, how I was, so much of my story starts in hospitals. I said, okay, let me give this a try. But crucially, this actually is going to be a report to the Ministry of Health. And the funding comes from the Ministry of Health. So I thought to myself, all right, if I'm going to have my lips to the government's ear, so to speak, how can I do a good job of this? How can I make sure that we take care of people, and how can I really focus on this? And the project became known as the Bridges and Barriers Project, exploring healthcare access and services for Indigenous peoples. And it was with me and two of my students, one who's actually in medical school right now and one who just applied, go Tina. So they're literally trying to continue practicing and taking these lessons into their work. So we will see a little bit more about the background. I think the challenge is many of us that are gathered here or that may be watching us, if you're Indigenous, this is unfortunately going to be very familiar. So I'm not going to spend a lot of time on things that we already know. I will invite you that if aspects of Indigenous healthcare might be unfamiliar, if you're newer to this field, or as you'll see in the next slide, if there's some things that you don't know, I'll invite you to read the report where I go into a lot more detail. But when we talk about what bridges are there, what barriers are there, Tina made this really stupendous graphic that I think highlights so many things. We understand that the continued, ongoing, and persistent barriers to accessing healthcare are all colonially rooted. It's through the systemic distrust, the personal experience of trauma and fear, the expectation, the warranted expectation of experiences of racism just to get to services, not only the experience of it, but the challenges every single step of the way before you arrive to the door, and then receiving inadequate or ignored care when you get there, continue to be perpetuated across healthcare systems. And this is what we already know. And surprise, 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 the results of this report actually support these things. We're seeing more and more of the same thing. And I think that becomes a testament to the systemic issues and challenges that we're going to continue to see, because we understand that a big part of these issues are, again, systemic issues. We see these reflections across the literature and in some of the results that we're going to continue to see, because the systemic issues haven't changed. We do know that what does help is not only cultural safety training, but Indigenous peoples leading our healthcare, understanding that there's so much more to care that needs to be involved, that needs to be reflected at policy, as well as incorporates our traditional knowledge. So it's a bit of a summary in one graphic or less, some of the background on the academic and gray literature about the barriers and enablers to healthcare. And this is what I mean when I say, if this looks familiar, if we understand what this means, then we don't have to spend as much time detailing those grievances, those healthcare and humanity violations that have been wrought on Indigenous peoples. This is unfortunately our reality. If in any way this looks unfamiliar, I'm going to invite you to read that background of the report to familiarize yourself, to help bridge those barriers yourself in understanding what healthcare has really looked like in Western systems for Indigenous people. So, like I mentioned, I was like, okay, if I'm going to be doing this work, if I'm going to be sharing perspectives of what the lived realities for Indigenous people are like to the Ministry of Health, my question becomes, how am I gonna do this? And also, I don't want to rely on just me. I only know so much. I'm going to ask people that are way wiser than me, that know way more, not only from the lived experiences of community members themselves, but I want to draw in Indigenous patient navigators who, number one, can speak across the breadth of supporting multiple patients, as well as know what the system navigation is actually like. What's the inside scoop to being in hospitals, working day in and day out? And with all my research, I always want to center our elders and knowledge keepers, because they're also reflecting their lived experience. They're also supporting patients, and they're able to draw on thousands of years of wisdom. It can't get better than that. So this is what I think when I think of, okay, if we're going to be speaking to the government, if we're going to be making policy recommendations, these are the people that need to be at the table, the people themselves and everyone in between who are accessing different bridges themselves within these healthcare systems, and are able to speak to the divide across different patient experiences. Now you'll see here there's a star beside the lived experiences of community members, and that's because the people themselves is sometimes the hardest to engage. Number one, because as we've seen in different quotes, we've been researched to death. The fact that this is another research effort is something that people have already answered. Actually, when I approached one of my elders to be a part of this project, they were like, haven't we already answered this question? And the answer is yes, we have answered these questions. We have identified these barriers before, but unfortunately, people keep asking, are the changes we're making enough? And the answer, as you'll see, is unfortunately not yet. But I was most concerned about asking people that have a history and a lived experience of navigating hospital centers. I was most worried. I was like, it's hard enough surviving these hospital centers. It's hard enough having that experience, but then to talk about it and trust that yet again, someone else will take care of it and it will resolve into meaningful change becomes increasingly hard. A large part, even actually in my clinical work, is navigating the mental health impacts of accessing medical systems, of the complex physical health realities that people navigate and experience, as well as what their physical health can, like challenges or even either disabilities or illnesses can impact towards their mental health. So we see a strong interaction in clinical care between these. So this was one I was is one of the most important voices, but I understood would be difficult to engage. And we see that reflected in the fairly small participant pool. Now, again, this is a qualitative project, so this is very in-depth information. But as you can see, only one community member confirmed and participated in the subject. Some people approached and some people, asked questions, but ultimately it was only one person. And I think that says so much about when we're engaging in this research. How much do people believe this is actually going to go anywhere? How much do we believe in these outcomes? And where is the trust and the sense of confidence in maybe not the procedures themselves through research, but understanding, is this actually going to help anything? Or maybe people are just also too overwhelmed and overloaded in their lives to sit down and revisit these things again. As much healing as I might be able to provide in that one moment, these are still very challenging, very difficult systems. But we did have a variety of both elders and Indigenous patient navigators across different settings in Ontario share their stories and experiences. But like I mentioned, it's a pretty small group of people. Again, it's in depth, and there's, as you'll see, we have lots of wisdom that come from it, but it's still quite small. That being said, there were some actual barriers to assessing these barriers. For doing research, we see a lot of challenges from the beginning of the project, from getting going to the contracts department, to navigating all the bureaucratic necessities that often accompany, especially hospital-based research, as well as navigating ethics and the timelines required for the project. And when all those things were sorted and we were finally able to get going, the actual deadline for the project for when the Ministry of Health would need the report by was only really a couple months away. And I was like, uh-oh, what are we going to do about this? So I asked the Wellesley Institute, I was like, hey guys, listen, I would like a little bit more time for us to be able to do this work. Can we have like more of an extension? They're like, well, we can extend it a little bit, but the Ministry of Health's deadline, and they're the one funding this project, is this specific date. And I was like, okay, well, maybe I can just talk to them and see what we can do. And they said, oh, no, they'll pull the funding if it's not in by this date. They have very fixed funding deadlines. So we see more barriers of they're asking us to do this work from a political and institutional level. But the rigidity in these deadlines become even more challenging when they are not accounting for the levels of barrier navigation, as well as the safety necessary to create safe conversations with this. So I said, give me their phone number. I was like, let me call and talk to them and explain these barriers and why they happen and why these are, even as best I can in navigating these different aspects for research, this is still a very short timeline. And it wasn't able to go any further. So even when I'm knocking on doors and trying to push barriers down, the barriers push back. And I think this is symptomatic, very strongly symptomatic of aspects of issues that we see in our healthcare systems. The barriers that are there can be very rigid. So I said, let's get creative. Let's do what we can. Let's talk to people we can trust and uplift their voices. And these are some of the results. So 5 main meta themes arose. Understandably, they all intersected in different ways, and I tried to reflect that within the colors that I chose to describe this. So some of them, such as bracing for racism, were difficult enough, but as you can see, there's some color gradients between the blue to the purple and even to the yellow, and that shows the illustration and the intersections between these different areas. So we'll go through the meta themes and really uplift the voices from the participants here. But the aspects of these main meta themes are bracing for racism in hospitals, so Indigenous encounters in Western healthcare centers. Traditional knowledge, of course, is care, and evolving education. So let's take a closer peek, shall we? So meta theme 1, hospital centers themselves. The results that we found from all these voices found that actually our healthcare challenges weren't even in direct care. They began before we even got to the door. It began when our patients and our people were thinking about accessing services and trying to get the documentation necessary. It began with the same levels of colonial impacts to different aspects of our health, to housing insecurity and how that impacts our access to medical care. It impacts how we're able to store healthcare documentation. It impacts how we're able to actually have access to our status cards if they've been lost or stolen. Are we able to safely keep medication in a safe place where it needs to be? A lot of people have insecure housing or may not have safe places to store these informations, or they may be lost because of different aspects of transience, including aspects such as phones, having a fixed address for follow-up care. All these dimensions, unfortunately, are lived realities for Indigenous peoples across all urban centers and are direct barriers to even being able to be seen in hospital centers. And as well, and you'll see this in its own meta theme, but the negative experiences, distrust, and only use of hospital centers in emergencies because of all the built up barriers that are there just before you get to the door. And we see this, unfortunately, throughout the literature. Now, this has been consistent even outside of this time period, but this has been covered through our Health Counts Toronto, and Indigenous peoples access emergency services in anticipation or in concern of racism for an emergency use. Usually it's not through preventative or follow-up care, it's returning to the ER to access emergent care because it's the most necessary. And this has been seen as twice greater than the general Toronto population for at least one time visit and accessing the ER, but also 6 or more times was commonly repeated at a 10 and 7 times greater use in general of Toronto and Ontario ER rates than other populations. So we're seeing that all these barriers create so much distrust that we're only really seeking these services in cases of emergency. Then once you get to the door, as if you get to the door, then when you get to the door, things like police presence, history and concern of persistent rejection or previous denial of service compromise even just staying. So it's an ongoing battle, but the war is not over when you get to the door. And one elder described they want to walk away as soon as they get in the door. And if they're doing this alone, that's even harder. But then again, one of the biggest challenges is some of the aspects that is commonly seen as simple, but carries a lot of tremendous weight, including aspects such as intake forms. Already people are navigating, feeling very overwhelmed, feeling a lot of the intense feelings of arriving to hospitals. And navigators have described one of their biggest roles in helping to find calm, to offer some smudge, to help them find some grounding in order to navigate through these intake forms. But also literacy is a big challenge. Without someone there to support and navigate their emotional well-being, it's even harder than to ask these very procedural, very sometimes very overwhelming forms. When Elder described, a lot of our people haven't finished high school, so literacy is a big problem. So if they say, okay, here, fill out this form, what are they going to do if they can't fill it out? They're not going to do it. They'll turn and walk away. For Indigenous patient navigators themselves, they found, number one, understandably, their roles were truly invaluable. The biggest challenge, though, or actually not, we'll get to challenges in a moment, but their successes lay in patient-centered, trauma-informed, cultural engagement and medicine use in their care, seeing the person as a human being, caring for them as a human being, recognizing what trauma-related overwhelm and overstimulation looks like, and having a ready intervention through skills, tools, and strategies and our ceremonies that can allow them to feel calm in the moment there for them. Having something as simple and as necessary as a smudge bowl was truly invaluable in just helping them stay to get the medical care they need. They also noted that the importance of awareness of our history, especially in hospital, being prepared for questions, and also normalizing how difficult these aspects and these interventions can be, become really important to have to help support that person in the moment. They're also able to navigate hospital system protocols, understanding the steps of what intake and triage can look like, helping with wait times. Those are the things that really became invaluable, helping to bring a lot of humanity to sometimes things that can feel very inhumane or very industrial. The challenge, this is where I was talking about, the challenge is that Indigenous patient navigators aren't everywhere. Sometimes there's only one of them. Sometimes there's a team, phenomenal, but sometimes there's only one of them and they have limited hours. Sometimes Indigenous patients actually may not self-identify. So even if there is a patient navigator there, they may not even connect to them because they're either concerned about it or they don't know what services could even be possible. And again, we see a lot of this through patchwork dimensions. Some of the navigator barriers are even when the patient is there, they've made it through the door, they've filled out the forms, they're waiting to be triaged. Some navigators describe their patients with severe and complex health needs are not triage, with the priority level that they actually need to be. And doctors assume that if a patient waited a long time to come in, their pain isn't that bad. The issue isn't that bad, which is a misreading of the real barriers that made them wait so long in the first place. So once again, we're seeing these barriers so endemic throughout every step and aspect of people's experiences. And we see these barriers persist at every level of care navigators. There is the barriers to accessing the Indigenous navigator themselves through staff not knowing who the navigators are, what their roles are, what the benefit is. There's administrative barriers, such as, again, filling out forms, as well as navigating if there's a technological form to triage, what that looks like. There's outdated medical services and forms that also contribute to challenges. And like I mentioned, unsafe housing and insecure storage of medical documentation. And then to the care attendants, we have, again, not only police presence really rising and contributing to the sense of overwhelm, but also experiences of violence from hospital security when seeking treatment themselves. Patients being denied or refused service, ongoing transportation barriers, or fear of welfare extraction and child involvement are institutional reminders if they do access care or disclose aspects of their care as well. Challenge. Our traditional needs and approaches, they don't stop just because policy or these hospitals don't understand what their needs are. That being said, the elders and some of the voices from this project say notice that we're going to do it anyway. Like any creature of nature, we're going to adapt to our circumstances. The problem is the barriers create further exhaustion and emotional weight on us to navigate these things. So one elder described, they wanted to gather to support a family member who was ill. They wanted to gather and have a smudge as a family. And they said they didn't have anything there for us to access where we could go as a family to smudge. So we went out to the front of the hospital and we had a circle. We took it over. There was 20 of us out there and all the kids and family were gathered there. They were able to make and create these spaces, but we shouldn't have to go to a hospital parking lot just to get some immediate grounding that we need. And it also denies the patient that access to that care and the ceremony involving their family. A lot of times Indigenous patient navigators would invite elders in to help with patient support, but then once again, the common Scooby-Doo villain, when we take the mask off, hospital policy would limit elders' medicine use, prescription of elders' medicines, traditional medicines that can help support us, as well as wouldn't disclose necessary health information to the elders because they weren't seen as family, or they would outright refuse their elder involvement. A lot of elders ended up actively navigating care for patients in the role of an Indigenous patient navigator as well. They also noted that there was a lack of appropriate discharge plans, transitional supports, and patient education. A lot of the information that was being delivered to patients when facing discharge wasn't something that was able to either be understood based on either health literacy or they were just feeling too overwhelmed about their health. And that elder there stepped into that role to be able to support and translate their needs effectively. One navigator described that some of these people are getting kicked out of hospital and have nowhere to go, and calls to different things like emergency lines or additional supports come from people who've been discharged and just don't know what to do next. So even the transitions out of hospital become concerning. Now, this is the one I think everyone expects to arise in these results and reports. And if it didn't arise, then I'm obviously asking the wrong questions. But a big question or a big statement that comes up when accessing healthcare systems is the normalization of racism, to the point where we termed it kind of bracing, or the brace for racism, knowing it's coming and expecting it in different ways. Some of it was overt, but we'll also see how it transforms over time. So some people have been asked, how much have you had to drink, even if that person says they don't drink. And then they needed additional supports because they kept assuming presenting information for patients or family members was because of the assumption of stereotypes of addiction or of substance use, when the reality was far from it. It was a health issue, and not even listening when they were being told that this was actually conflicting, and instead being met with assumptions and stereotypes such as, well, all Indigenous people drink, or normalization of violence. Oh, they're here again. She got beat up again. And this is where, when we think about physical health and symptomatic terms, I like to think about the importance of racism as a malignancy that continues to spread. It continues to fester and foster. And the challenge is, even if it's not outright in your face symptomatic, it continues to be endemic into interactions, whether it's overt or covert, was something that was very much discussed. So in the way racism was captured in these experiences was not only those overt experiences, but the way physicians and other care staff deprioritized, ignored, or denied patients essential tests or diagnoses. Often service workers noted that healthcare staff would speak to the patient, not to the patients, but to the service workers, as if the patient wasn't even there. Some people described that they were being denied testing experiences that wasn't done through the same protocols and standards that would be present for other non-Indigenous people. They described, I brought it up to my family doctor of a healthcare concern. I didn't have all the words for it, and I did my best to explain it, but she was still, no, you would have been tested for that as a baby. No way that would have happened. We catch that early on, and that's not the case. Leaving them to deal with the impacts to the long-term effects of that specific medical issue. So once again, despite cultural safety trainings, and this is the important part, even when that checkbox has been ticked off, racism was still identified in the deprioritization, the ignorance and ignoring people, or denial of Indigenous patients' tests and diagnoses, ignoring Indigenous patients themselves, or infantilizing patients, so speaking to them like they're a child, or not explaining procedures to them, speaking only to the navigator, the assumption of substance use or violence, and the failure to disclose medical treatment or follow-up care. Now, with these major gaps and barriers to even standard Western healthcare, we obviously know that we still need care. These gaps don't make these services or these illnesses that we're arising to go away in any way, shape, or form. In fact, they'll worsen. And that's where our approaches and our knowledge comes in to save the day. This is where our understanding of what healthcare is, of how we approach medicine, and how we keep that medicine as part of our lives is essential to not only our daily lives and maintaining our well-being, but actually actively helps to meet the gaps that these service failures and anti-Indigenous racism in these services unfortunately cause. All participants in this project describe the importance of Indigenous traditional knowledge approaches as a way of life for us. Surprise, surprise. Western medicine doesn't recognize the legitimacy of traditional medicines, even when pharmaceutically based medicines that are available now on the market are rooted in our medicines. There's still a lack of care, understanding, or awareness for the necessity of our practices in our life, or the fact that they could be potentially helpful for someone else. One elder described, this is what we do, either through end of life ceremonies or funerary practices or just needing grounding. They're like, this is what we do. It's not something we might do. It is what we do, either in the hospital, the morgue, or at the funeral home. Somewhere along the way, our medicines find us to guide us. And an element to this, I think, is also important is, of course, people are navigating their access to cultural care, or they might be closer to medicines, or they might not be that close. And that's okay. But for those that need that care in hospital settings, there continue to be closed doors and barriers. A key aspect of this becomes really important that when we do have Indigenous representation in hospital settings, it makes a difference right at the door. The same way that we can anticipate harm right at the door. When we see signage, when we see languages, Indigenous representation through staff, through our arches, through our greetings, that's when we're able to create a different outcome through the security of safety. When Elder described accessing a positive space like that, that was an Indigenous-based healthcare center, by saying, I felt comfortable going to this clinic. The receptionist spoke Ojibwe and greeted people in the language. I felt good that way. It sets a different precedent. And we're seeing more of this, which is good, which is so, so good. At St. Mike's, we now have an Indigenous Wellness Center. The challenge is it's not at every hospital. The challenge is it's not at every clinic. And the challenge is, even if it isn't an Indigenous health center in and of itself, there's still such a deficit of understanding why these approaches and why these medicines are necessary, as well as a deficit in understanding how our needs and experiences are different. Surprise, surprise to anyone, there's a lot of information from these voices about every single step of aspect of our healthcare can have and should have different aspects of medicine use, from the emergency room, from the ICU, patient experiences in their own room, as well as birth to death. There's a place for our medicines because that's where our medicines have always been, right beside us. They've been supporting us along the way. And I think I say this in another slide, but I'll jump to the chase of there's always tremendous respect for the medical equipment that's in the room. There's an awareness that there's the potential, although rarely experienced in my own experience, but that's okay. There's the potential for, either things like smoke or smudge to impact with some of the machines. Now that might be a very cautious approach to it, but there's still a lot of flexibility from our people to say like, okay, if we can't use maybe smoke-based smudge, we'll do cedar water or smudge water for cleansing. Cedar waters, teas, that says tropical treatments. It actually should be topical treatments. Hydrosols, singing, drumming. There's there's so many aspects of ways that we're able to adapt flexibly. We just need people to work with us and give us some space to do so. And this is what I meant earlier about not everyone may be as close or hold their medicines as close as possible, and that's okay. But a lot of people have found that when it comes to our way of life, when people are navigating, especially transitions into severe sickness or are looking towards joining or looking towards the spirit world, there's very commonly a call for connection to their culture. A lot of elders are called on at that time to provide end-of-life ceremonies and protocols. And one elder described, we need to have a kit or an understanding in systems to support that end-of-life protocol. It should be there so we're not running around before, unfortunately, their time may be up or the clock may run out to be able to provide that for them. We want to send them home in a good way, and we want the systems to support that and not waste our time. So some of the prescriptions for providing real medicine, what our medicines actually mean, you like my little joke there, is we need settings in hospitals that are dedicated to allowing smoke and our ceremony. Doesn't mean we're going to have a big bonfire inside, don't worry, but we need flexible, accessible access to spaces where we can drum, sing, or smudge, with or without patient navigators. Sometimes I think they described in some of the reports that the navigators were able to access that space on behalf of the patient, but there's all sorts of emergencies or need for smudge outside of those aspects. We need materials for ceremonial preparation. That was a recommendation that was also provided by one of the elders of the importance of having smudge bowls there, even separate materials for making things like cedar water if there's going to be some either teammate or some supports for washing people as they transition as part of the funerary process, having that right there and available, and even participating if it's okay for the family. That was something that can make a huge difference for just navigating these aspects. And like I mentioned, there's always respect for ventilation systems. We're just asking for respect for our medicines too. So understandably, um, there's a lot of ignorance when it comes to racism. There's a lot of hatred when it comes to racism too, but a lot of our elders' teachings were saying that if they know better, they'll do better. If they understand and connect from one person to another, they'll hopefully be able to see us more as people and understand that we're actually not so different. We just might have a slightly different way of doing things. The key education component and the recommendations through this meta theme, we're strongly supporting the foundation of education to support common humanity and empathy. That becomes an essential key of minimizing the changes and challenges for people that then become dehumanized through those barriers. So the key education points were, of course, colonial education and the impact in medical systems, understanding cultural approaches and ceremonies, why we like them, and where the Indigenous patient navigators are. But also, if that's not something you feel comfortable knowing about or speaking of, recognizing its importance for someone else is a-okay, but know who to call to deliver that service in your stead. So I think I wanted to include this as a bit of a tongue-in-cheek discussion regarding the creation of a lot of clinical training programs in the healthcare system. And I don't know about it recently came out, but it was new to me, that is for sure, in that the influence and the creation of residency training, especially in North America, the individual, Dr. Halstead, was actually quite addicted to different substances at the time in order to meet these tasks, different stimulants to make sure they had time to meet these needs. And I think about that significantly when I hear about people's medical training and how long their shifts are. And I suppose helping to build that capacity to be able to work as effectively for such a long period of time. But all I hear from that is the need for so much of things that take us out of our natural rhythms, denying sleep, working in emergency settings through sleep deprivation, long call hours. I think a lot has been said about Indigenous people, but we know that a system like that is going to actually create ill health. We know that if you need that level of stimulant and it's rooted in that kind of approach, there's going to be something wrong. We're really good at knowing when something is wrong. That's why we employ our medicine wheel. We look at things through different ways, and we're really good at curing everything along the way. And I think it's important to understand and recognize the contrast between these levels of understanding what these barriers look like. And unfortunately, how when we train through these types of institutional systems, we might actually dehumanize ourselves as well as others. Another person described that education for the people accessing services is not just the staff that also need to be educated about us. We also need further support in understanding what the experiences are like, what we can expect when we're accessing healthcare, as well as supporting someone along the way so that they can understand the information they're receiving. Like I mentioned, the patient navigators, as well as actually this example is kind of misput. That's my bad, but if someone doesn't have access to like appropriate prescription for their lenses, they said that they were timid and saying that I can't read this because I can't see. I haven't been able to visit someone, an optometrist, to get my lenses corrected. And they felt very hesitant to say, can someone read this to me? Because it's not their job to do that. And you don't want to be perceived as dumb. So there's multiple barriers to even understanding the information if everything else is accounted for. So this is actually not included in this project. This is a sneak peek at another project that's going to be launching very shortly. But when we talk about understanding cultural safety through our education, the barest foundation is understanding Indigenous racism in healthcare, the colonial history and health impacts, and understanding personal biases and addressing stereotypes. Very commonly, that's a front line for a lot of cultural safety training, but that still doesn't take people where they need to go. Commonly, a lot of people ask me, Mikaela, I was really moved by understanding what I didn't know. I'm very active and I want to be a good ally, but what do I do next? And some of the information that will be forthcoming is taking it and applying it in necessary ways. And we need to do that through system and managerial support. It's not enough for one person to be really well trained in cultural safety and know all the right things to do. They also have to have teams that are able to meet them there and commit to lifelong learning of decolonization. They need understanding of diversity, of trauma-informed care and community engagement, as well as what skills, protocols, case studies, and holistic health approaches look like in their actual practice. And that's why I think there can be a lot of challenges when it comes to these aspects of racism and exploration, is that people are learning that little sapling level of soil work, but they're not understanding how it relates to them in their experiences, how that need for advanced care looks like in the day-to-day interactions and how that can inform in their behavior. We need a lot more development when it comes to putting the next steps in order. Now, I know we're getting short on time, so I'm going to try and move through these things gracefully, but no less thoroughly. So this is meta theme 5 and the title for the talk, prescriptions for policy. We recognize that these approaches have and will continue to fail Indigenous peoples because they lack the appropriate educational, political, cultural, I dare say humane, and holistic understanding to adequately treat our health needs. I mentioned this before. My concern, as someone who's gone through extensive and rigorous clinical training, not to the level of medical school, but still quite extensive, if your training to become a clinician requires you to divorce yourself from what it means to be a human, the system can't be a healthy one. Of course, there's a necessity for objective clinical work. Of course, no one's saying that's unnecessary. But if empathy is last on your list of your clinical interventions, something is really wrong. If you're not seeing people as people, something is wrong. And I think that's endemic to the structure of these approaches through an industrial lens of profiting a lot of patients in a short period of time. Individuals alone need system support to dismantling these barriers. It's not possible for one person to do all this work. The Indigenous patient navigators were doing their best to provide so much of that care. But if they keep running into barriers, they're not going to be able to go much farther than they're able to share unless they're able to share their voices as best they can. Without policy rooted in systemic integration for health needs, we're only going to continue these failures. And treating the symptoms through case-by-case basis won't actually cure the illness. And we know that from physical health. If we're only treating the symptoms, these things are just going to keep coming back and people are going to keep asking questions. So great news. We have lots of recommendations. A lot of these research aspects are asking us, what's the answer? And we have lots of answers for you. Increase things like funding to support Indigenous health teams and programs, include elders and communities in providing feedback and discussions, share successes across hospitals, review feedback from the people, engage youth in these partnerships, and include Indigenous leadership as part of hospital leadership. And that way we're able to represent and see ourselves through dedicated, inclusive spaces. So I thought it'd be kind of cute to include prescriptions for policy, like I mentioned before. So the prescription from our people to medical systems is that Indigenous education needs to be provided because it enriches, engages, and fosters empathy through common humanity. It offers flexible approaches to the diverse needs and backgrounds of Indigenous patients. Our skills need to be person-focused for trauma-informed care, have cultural representation and sovereignty in medical directions by knowing what these are, as well as offering training-specific and scientifically substantiated cultural safety so we know that when we're doing that training, it actually works. And like I mentioned, the necessitude of community engagement and feedback. Warning, if you take this medication, if you take this prescription, it may increase empathy to other human beings, and that's difficult. It is to be taken at direction. If you follow these protocols, if you follow these prescriptions, it's to be taken at direction of elders and other knowledge keepers. But good news, you can use traditional medicines not only as prescribed and following these prescriptions, but as frequently as needed. The challenge is inadherence to treatment or treatment failure will result in serious risk of harm, dishonor, degradation of trust in healthcare professions for multiple generations of people. If we don't follow these prescriptions, more and more people are going to be harmed and their lives can be lost. Now, I mentioned through and through, and this is our third to last slide, that I'm not that kind of doctor. I can't actually write these prescriptions. I can only talk about them and share them with you. But I am this kind of doctor. I am someone who's able to diagnose and navigate care settings. I am able to make certain patient orders and navigate care on their behalf. But I also know it's not enough to address the illness. It's necessary to have good medicine along the way through each and every one of these slides that help heal us from the experiences of the pains and the wounds that we're navigating. Now, I know we're probably well over time, so I apologize for the depth and detail, but I just wanted to share everything with you. If there's any feedback, if you want to discuss further, ask questions, my information is here. You can contact me directly. You can also read the entire report online with beautiful signage and beautiful illustrations. That's available through the wellesleyinstitute.com, and you can search Bridges and Barriers and you'll find it. So without further ado, I'll stop sharing my screen. We can go back. Oh my gosh, we're right at 12. I can't believe it. I thought for sure we would be well after time. So if there's any questions or any comments, or if people want me to go back and clarify something, I'm really happy to do so.
Which Mikaela, that was so wonderful. I really want to have a chance to I'm gonna look at that report.
Okay. And I think a key
Yeah,
part, sorry, Shanti, just before you go
yeah.
on, I think there's this hesitancy with seeing published things. If there's something in there where people are like, I want you to add this or something, let me know and I can like contact Wellesley and say like, hey, like these are the feedback we have. It's not carved in stone. It's online, it's flexible. We'll keep integrating feedback and knowledge. So read the report, let me know information, keep me posted on things. But yeah, thank you.
Yeah. Yeah, no, I'm so excited and to share it with everyone too.
Thank you.
We have a few questions.
Okay.
So I'm happy to read them out. I know we're right at 12. I think we can go over a few more minutes, but I will have to hop off because I have another meeting at 12:10. Yeah, but I think we can go for a few more minutes. So the first one is from Vanessa. She says, Miigwech Mikaela, I am meeting with the mental health hospital next month, not here in Toronto. They are in their very earliest time of learning and have asked me to offer education to, in quotes, increase awareness about what happens when Indigenous peoples come into contact with the hospital. She says, I really respect your comment about how we need to be aware of the determinants of health before someone enters the door. And then the question is, what does the hospital know to do better?
Oh, okay. So great news. I'm not trying to be like, go to the report, but I can, if Vanessa, if you want to email me directly, I can just copy and paste where the recommendations are from the Indigenous patient navigators, just to make your life a little bit easier. I think that your job is doing a lot of that important frontline work. So I'd like to thank you for it. One of the most important things that was recommended by the navigators was having a lot of supports available for patients, and that includes taxi chits that are offered flexibly, not only so they can go home safely, but also return safely for follow-up appointments. So having a lot of flexible supports for either taxi chits or a medical service to pick up patients from wherever they may be. And sometimes there is awareness of geographical distance, but flexibility in just having them to the door asking if they would like an Indigenous patient navigator or another staff to greet them, to be there with them through the appointment is always an important aspect. Seeing if they would like smudge used either for that appointment or for other appointments. Sometimes hospital systems are aware of smudging policies and are totally on board with them, but they require advance notice. So if that person is connected to if their medicines or they might like that, we can know when the appointment is in advance and put that request in advance, just in case they might like to smudge. I think the biggest aspects are asking if they would like a patient navigator there with them, if there is one, but also the flexibility of accessing the appointment through transport itself and having that as a wraparound service. And then I'll go so far as well as if they are close to other like Indigenous community service providers, friendship centers, if they are nearby, having the list of those contacts to provide the patient as well, or just that the hospital's familiar with additional services that are provided would be very helpful. So again, maybe they don't have an elder that they work with, but a nearby friendship center does. They can be like, you know what, if this is something that you're interested in connecting with, this is the location and the number for the friendship center. We can help connect you with them if that would be something that can complement your care. But if there's anything else that those are just the things off the top of my head, but please email me if there's anything I can provide or sum up in more concrete terms for you.
Rich, Mikaela. So the next question asks, did your research and investigation include a review of coroner's inquest recommendations and/or for the NI into the MMIWG recommendations, including the regional distinctions by population?
It did not actually. Unfortunately, that might have been a challenge with search terms. But unfortunately, a large part of the query that was recommended for the literature search was just access to hospitals. And I think that's a challenge when it comes to so much of Indigenous research and data, is that there's so much wealth of information out there that I'm always continuously and constantly learning. So actually, I want to copy and paste that comment so I can go in advance and look that up further, make sure that when I deliver presentations like this or make future recommendations, I can also include that information as well. I think a big challenge is a lot of especially sometimes political domains when it comes to these types of research. Even if those recommendations have been made again, they're asking researchers to explore these things, and very commonly we can kind of be recreating the wheel over and over again. So there might actually be phenomenal recommendations like that one out there that would do. Oh, hawk just flew by my window. Okay, I've got work to do. Fun fact. Anyway, but that can complement or uplift even further by region to support these areas. So thank you for that, and thank you for pointing out a new area for me to learn.
Yeah, and I've copy pasted it, so I'll send that to you.
Thank you.
And lastly, this is just a comment. It says, as a recent transplant recipient, I was told I could not take traditional medicine because herbal remedies can impact rejection.
Hmm.
So
So
it's just
first
another
off,
experience. Yeah.
yeah, that's a challenge. And I think this is, I really hope that you're able to receive the supports you need through your transplant. That goes without saying, as a tremendous sometimes ordeal in navigating your healthcare and placing a tremendous amount of trust to ask someone to help you heal, both in terms of the physician and the organ donation itself. I really hope it's as smooth and an easy process as that ordeal and rigor can provide. I think one of the challenges is, my question is like, what are they concerned with? What's these are just questions that we don't know, but is there science backing up why they think those remedies would be bad? Or is it just it's an unfamiliar approach and they're not willing to listen more or even meet with an elder who could prescribe or provide those medicines about what are the active things that are there to help that person. I think there's so many deficits in these approaches that it could actually help a tremendous amount. The problem is we don't know. And out of an abundance of caution, people are following their doctor's orders, and there's strengths to that. But what if we're missing a key element that could help the healing? And that's where my concern is. We need to ask these questions safely. So much much wellness and speediness for your healing. Kind commenter, and I hope that you're still able to receive as much other medicines as you need as best you can.
Okay, so I will invite our elder to close this out.
Thank you so much, everyone.
Miigwech Clay
Thank you, Clay. Thank you,
and
everybody.
Miigwech Mikaela. And thank you so much, everyone, for joining us. Take good care.
Thank you.